Types of eating disorders. Anorexia nervosa, first one, which is restricting type or binge eating type / purging type. 2. Bulimia nervosa. 3. Binge eating disorder. 4. Eating disorder in childhood, which is pica. Anorexia nervosa. Diagnosis features: 1. Extremely thinness. 2. An intense fear of gaining weight. 3. Disturbance in experiencing weight or shape. Subtypes: restricting type, binge eating / purging type. Anorexia nervosa diagnostic features: starvadic thinness. First, extremely thinness, the hallmark. Refusal to maintain a minimal normal body weight, no weight cutoff. Conventionally 85% of expected body weight, BMI _ less than 18.5. 2. An intense fear of gaining weight, behaviors interfering with gain weight. Anorexia nervosa, starvation, thinness. Disturbance in experiencing weight or shape, distorted body image, undue importance on body weight / shape, lack of recognition of seriousness of body weight. A girl looks in the mirror and pictures herself fat when in reality she is skinny. Anorexia nervosa, subtype: restricting type, restricting calorie intake or severe exercise, binge eating / purging type, recurrent binge eating or purging. Prevalence. Onset 16 to 20 years old. Highest mortality rate of any psychiatric disorder due to organ damage. May cross over to bulimia nervosa. Course: high, variable. Recover after one episode of fluctuation, chronic and deteriorating. Physical complications. Physical complications can be serious and lead to death. Amenorrhea, a reaction to the loss of body fat and associated physical changes. Lango, fine hair on face or trunk. Starving, brown burrows energy from internal organs. Cardiac damage, heart attack, kidney damage, blood pressure and body temperature may fall below normal. Osteoporosis. Bulimia nervosa. Diagnosis features: 1. Recurrent binge eating accompanied by inappropriate compensatory behaviors once a week for 3 months. 2. Undue importance of weight and body shape on self-evaluation do not occur exclusively during episodes of AN. Question: how is bulimia is different from AN, binge and eating / purging type? Bulimia nervosa diagnosis features: binge eating compensatory behaviors. Binge eating a clearly large amount of food in a fixed period of time, lack of control over eating. Planned or spontaneous, often triggered by unhappy mood. Bulimia nervosa diagnosis feature: inappropriate compensatory behavior make up for binge eating. 1. Purging, most common self-induced vomiting. Misuse of laxative, diuretics and enemas. 2. Excessive exercise. 3. Fasting or food restriction. Bulimia nervosa facts. Prevalence: females 1 to 3%, males 0.1 to 0.5%. Onset: adulthood to early adulthood. Gender: 95% are female. 7% of college women suffer from bulimia at some point. Better progress compared to anorexia nervosa. Physical complications of bulimia nervosa: erosion of tooth enamel, electrolyte imbalance, irregular heartbeat, seizure, vomiting, dehydration, swollen salivary glands. Low potassium can cause heart attack, kidney failure, permanent colon damage. Binge eating disorder. Binge eating, no compensatory behaviors. Diagnosis features: binge eating once a week for 3 months. 3 of the following: eating rapidly until uncomfortably full, a lot when not hungry, eating in secret, feeling disgusted with self, guilt, or depressed after eating. How binge eating disorder is different from bulimia nervosa. Binge eating disorder associated characteristics: likely to be overweight, 20 to 40%, and weight color programs have BED. Binge eating disorder may remain overweight. Personality and conformity in binge eating disorder. Newly introduced to DSM. Few studies. Comorbidity is similar to other eating disorder, depression and anxiety, substance use, and impulse control disorders. Check your memory. For anorexia, body weight severely underweight. For bulimia, body weight normal or slightly overweight. For binge eating disorder, typically overweight or obese. Anorexia, fear of weight gain, yes. Bulimia, fear of weight gain, yes. Binge eating disorder, fear of weight gain, no. Anorexia, body image distorted. Anorexia, binge eating only for binge eating type. Bulimia, body image overly concerned. Bulimia, binge eating, yes. Binge eating disorder, body image may be concerned. Binge eating disorder, binge eat, yes. Etiology, social dimension. Cultural beliefs. Countries where food is scarce. Being larger is beauty norm. South Africans and Fijians traditionally valued fuller size. Dramatic increase in eating disorders are after being exposed to Western culture. Etiology, social dimensions, gender, Western culture. 2. Thinness for women. %69% of Playboy contestants for the 60% of Miss American contestants weigh 50% below the expected weight for their height. Difficult to achieve. Women are socialized to be conscious of body shape and weight. Body objectification. Cognitive behavioral therapy, psychoeducation, addressing distortion on body image, eating, and weight. 2. Family therapy, the Mandusuli method. Parents take complete control of child's eating. Later, the patient gains autonomy as one's eating improves. 3. Inpatient treatment, weight restoration takes priority. Often involves an interdisciplinary team. Etiology, biological factors, brain abnormality, damage to the frontal and temporal cortex. Reduced gray matter volume in certain areas. Anorexia. Reduced gray matter volume in certain areas. Anorexia. Increased gray matter volume in certain areas. Bulimia. Hypothalamus, the ventromedial area, is satiety center, the lateral area, and appetite center. Like stop eating. Etiology, psychological factors, low sense of control, a key psychological factor in the development of eating disorder. Perfectionism, unrealistic high standards, self-critical, demanding flawless performance from themselves. Achievement orientation, good students, excellent athlete, competitive careers. Low self-esteem lead women to be preoccupied with their social self. Etiology, psychological explanation. Restricting eating motivation by desire by thin, leading to binging or eating restricted foods, leading to vomiting. Excessive exercise, laxative use, leading to repeat. Leading to the first one, restricting eating motivated by desire to be thin. So, etiology, social dimension. In what way do you think family and peers influence eating disorder? Family and peers influence. Family members with anorexia are often high achieving, concerned with external appearance, disoriented eating also strains family relationships, parental guilt and frustration, leading to poor outcome. Adolescents are likely to be influenced by adults about body shape and weight of their peers. Biological treatment. Medication. No specific medication for eating disorders. Fluoxetine, like Prozac, is the only FDA-approved medication. Medication alone is not effective and relapses once stopped. Nutritional counseling, examining eating patterns, setting appropriate weight goals, developing strategies to normalize eating. Necessary but not sufficient. Eating disorder in childhood. PICA. Diagnosis feature. Children with developmental disabilities make up the largest group. Also seen in people with intellectual disability, schizophrenia, and with no psychological disorder. Can result in serious health components.